Hello and welcome to the DySIS Medical webinar. We have, I think, around 60 participants from 6 different countries on the line, so very warm welcome to everybody and thank you for your time in participating. During this event you'll have the opportunity to hear about the experience of using the DySIS Colposcope within a leading UK centre. This centre is called the Northern Gynaecology Centre and it's part of the Queen Elizabeth Gateshead Hospital. I'd first of all like to introduce you to the NGOC team. We have with us on the line Mr. Raj Naik, who is the Clinical Director at NGOC, Dr. Anne Fisher, who is a Consultant Gynae-Oncologist, Dr. Christina Founter, Gynaecologist, and my name is Alistair Atkinson, the CEO of DySIS Medical. The agenda that we're going to cover today are the following. After a brief overview from myself about the unique capabilities of DySIS Colposcope, Mr. Naik will then provide some background about the Queen Elizabeth Hospital and in particular the use of DySIS within the NGOC. We're then going to move to Dr. Fisher, who will then present her perspective of the impact of DySIS concerning those areas of quality assurance, documentation and medico-legal subjects. Dr. Founter will then review the results that she has achieved of using DySIS in clinic in the NGOC, and specifically her results in using DySIS on high-risk HPV-positive low-grade cytology patients, arguably a very challenging cohort of patients, and also using DySIS as a test of cure on patients who've received a LEAP or LEX procedure. And then finally, Dr. Founter has some very interesting case studies to share with you on particular patients. I'm sure that there's going to be plenty of questions as a result of the NGOC presentation, so if you do have a question, please submit it to the panel by typing it into the questions box that you'll find in the GoToMeeting control panel, and we will address as many questions as we possibly can in the time remaining at the end of the presentations. So by way of a brief reminder about DySIS, it is a colposcope, but it of course has a very special adjunctive feature. DySIS provides all the features that you would expect from a standard colposcope to properly visualize the cervix. Not only does it provide you with a very high resolution image, but of course you can magnify, apply green or blue filters and capture photographs. Secondly, whilst you're performing the normal colposcopic evaluation, DySIS is measuring and quantifying the cyto-whitening effect, and it produces the unique DySIS map, which you can then incorporate with your other observations of vessels and lesion margins. Finally, DySIS helps you to standardize the colposcopic exam, not only through the DySIS map measurements, but also through the comprehensive documentation that is automatically captured as a result of doing a DySIS exam. Here's an example DySIS map. As you can see, it's intuitive to read with the bright colors being used to highlight areas of intense cyto-whitening. DySIS map is therefore an additional piece of very valuable information to incorporate with the normal colposcopic observations of vessels, lesion margins, and your own assessment of the cyto-whitening effect. In doing so, it standardizes much of the colposcopic exam. It provides first-rate documentation of the exam, which in turn enables longitudinal tracking and conservative management. Now, I do have a very brief regulatory statement that I'm required to read out. DySIS Advanced Cervical Imaging System is FDA cleared as substantially equivalent to a colposcope with an adjunctive imaging map. The following information is meant to be educational only regarding the experience of a teaching hospital in the United Kingdom and may contain claims of superiority that are not within FDA cleared labeling. With that said, let me now hand over to Mr. Raj Naik, who will give an introduction to the DySIS program at NGOC.
Thank you, Alistair, and welcome everyone from around the world. Good day, and for those of you in Japan, good night. Just to give you a little bit of background on our department, we are the Northern Gynaecology Centre. We're part of the National Health System here in the UK. We're predominantly in the northeast of England, and we cover a population of about 2.1 million within the northeast. We're predominantly a gynae cancer centre, but we also provide a local colposcopy service to the local Gateshead population. We receive about 800 gynae cancers per year and about 800 colposcopy new referrals per year. We have a strong reputation for research and a strong collaboration internationally and nationally in relation to those research projects. and we particularly have interest in technology that adds value to practice. On the basis of that, we pioneered the one-stop colposcopy service a number of years ago, which utilizes the URM microwave processor that allows histology results of small punch biopsies within 2 hours and allows us to then carry out a loop biopsy for confirmed high-grade sin the same day. It's on the back of that work that we got interested in the DySIS Colposcope, following initial work that was done at the Hammersmith and in Athens. And on the back of that, we approached DySIS Medical and Alistair in particular and purchased our first colposcope last year in 2013. I should stress at this point that we are an independent organisation from DySIS Medical. We have a contract in place between DySIS Medical and our organisation that allows us to research and carry out assessments of the DySIS Colposcope at arm's length from DySIS Medical, so we are independent. But we also carry out workshops for training opportunities for those that are interested in purchasing the DySIS Colposcope as well. On the back of that, we've been doing research which has been mostly led by Christina Founter and Anne Fisher, who are both sat next to me today. And our intention is to expand the DySIS usage within our department over the course of the next few years. I'm not planning on saying very much today because I'll be handing over to Anne Fisher next, who's going to be talking about some of the evidence and background to the DySIS Colposcope, and in particular concentrate on areas around improved sensitivity, standardization, as well as objectivity that we've seen in relation to the DySIS Colposcope. Thank you, Anne.
Thanks very much for the introduction, Raj, and hello to everybody. As Raj says, I'll talk a little about quality assurance and documentation. Within the United Kingdom, our colposcopic practice is really quite heavily regulated. We've got an NHS cervical screening program which falls under the umbrella of Public Health England, and under that umbrella we have cancer screening programs and more specifically the cervical screening program. Everybody who practices colposcopy requires registration with the British Society for Colposcopy and Cervical Pathology, and our work and quality of work is policed by regional quality assurance reference centres, and we fall under one to do with the North East and Yorkshire. We receive referrals directly based on national guidelines, and we see patients coming to colposcopy based on cytology specimen results, and all of our management is based on guidelines. Our management is audited both as individual colposcopists and also as a colposcopic unit, and our colposcopic unit has mandatory inspections and has certain criteria that we have to achieve to continue to perform colposcopy. So as we all know, there are areas of good practice in colposcopy and areas of challenges. And for good practice, we'd like to be able to diagnose and treat high-grade lesions. Even more importantly is to safely discharge patients who do not require treatment. Within the BSCCP guidelines, there are protocols for following up patients who have had certain cytological diagnoses and have subsequently been seen with us. And it's almost as if you have a safety net for when you will perform your next cervical cytology specimen. For people who have confirmed high-grade lesions, we do the test of cure cytology with both a cytology specimen and an HPV test 6 months after their treatment, and that's a group of interest that Christina is going to tell us more about. People who have low-grade histology will receive cytology in 12 months' time, but other women who have histology which is less than low-grade will have cytology in 36 months. So it's essential that we are very confident in our colposcopic diagnoses. We really need to be good at differentiating between low and high-grade lesions, and as we're aware, the internationally agreement is poor amongst colposcopists, more particularly in the low-grade referrals. Again, to do with regulation, the BSCCP audits us, and our predictive value of a colposcopic diagnosis of CIN2 or higher should be 65% as accredited colposcopists, and we're all keen to avoid unnecessary biopsies for patients, and we'd like to concentrate on biopsying the right area. So there's a lot of subjectivity in colposcopy, and what DySIS brings to the table is an objective adjunct, and that's been very helpful in our practice. If I go into the next slide, this is some market research done by DySIS. I've put this in as an example. There was a BSCCP conference. A number of colposcopists were walking past the stand and invited to have a look at these images and see where they thought the high-grade lesion was. You have the advantage of the DySIS map over the top here, with this being the highest grade area. And I don't know who's familiar with pin the tail on the donkey, but this is a little bit like pin the tail on the donkey, and you can see that the clinician's selection varied quite widely in these patients, particularly with the low-grade cytology referral. So that's what we're looking to optimize. All new technology obviously needs to be approved. We need to use CE-marked equipment, and the National Institute for Health and Clinical Excellence had a diagnostics guideline and guidance assessment in 2012 where DySIS was approved as an adjunctive colposcopic technology. Also, there's a technical document that's been published under the NHS Cervical Screening Program backing that up as well. So the technology's been approved, and the evaluation was done using DySIS as a standalone test, as well as DySIS as we use it, which is an adjunct to colposcopy. We know that overall, for all referrals, there's a higher sensitivity. Sensitivities are 80% versus 52%, and a reduced specificity of 63 versus 82%. But in low-grade abnormalities in particular, sensitivity is greatly increased. We know that this technology is clinically effective, and that's when we take into account consultation time and consults required, as well as patient outcomes. It's cost-effective, even taking into account purchase price, maintenance of the equipment, and per patient consumables required. And again, the NICE assessment has shown there are more quality-adjusted life years at lower cost. And this is largely due to increased sensitivity, increased accuracy of diagnosis, and the provision of correct management promptly. One of the things that's a huge bonus is documentation. Now, I guess you all will have your standards of what you consider appropriate for documentation. As far as interpretation of colposcopic images goes, it's fairly subjective. We have quite detailed written documentation, but our actually documentation drawing lesions is hand-drawn, and I'll show you an example in a moment. And it does rely upon the same colposcopist time after time interpreting the cervix. Whereas the advantage of DySIS colposcopy is that the images are objective, you can review the saved images, and these are readily available with corresponding clinical information because we insert that into the system in parallel with our images, and it keeps a longitudinal record. We also know that you can ensure that your data is securely saved. And I'll show you an example. Oh, there we are. That might be one of my diagrams there of a lesion on the cervix, whereas, as you can see, DySIS colposcopy is a little bit more detailed than what I usually draw. Okay, so the next thing I'd like to talk about is medico-legal issues, and I'd like to be clear that all this technology is integrated into our current practice and falls within our regulatory framework. We are very happy with quality assurance issues surrounding this. Data transfer is compatible with our local systems, and the data is safe and secure. And documentation clearly is greatly enhanced above what we would normally collect. And I think medico-legally, some of our highest risk patients, because we work in a center where there are a number of colposcopists, we have what we term colposcopy correlation meetings every week. And these are really meetings where we bring to the table cases of mismatch or any concerns that we have that we think management doesn't fall within standard guidelines. And there we have multiple experts who actually are relying upon an individual examination and interpretation. And what we've done from now, from fairly, since the introduction of our DySIS technology, is that all of our high-risk cases we now are reviewed on DySIS, because DySIS has raw images and it allows the MDT to be a little bit more robust in its approach and a little more objective. And we also audit and record the outcomes of all of these high-risk cases. So that's very helpful to us. So in summary, if I click on here, we find that this is an objective adjunct to our current practice. It's clinically effective, it's cost effective, quality assurance is high, medico-legally we feel that this adds value, and what I haven't talked about is training, but this is a fantastic tool for training colposcopy trainees. It's great for personal development because you can instantly review your results, and once again adds value to our current practice. So thank you very much, and I'd like to hand you over to Christina Falter, who's going to talk to us about her research projects using the DySIS Colposcope. Thank you, Christina.
Thank you very much, Anne. Hello, everybody. So I'm going to present to you our experience with DySIS in Gateshead so far, and I'm also going to present to you the results of our research projects. So as Anne already talked to you, Anne has already talked to you about this. In the UK, the NHS Cervical Screening Programme suggests that NHS colposcopy clinics receive specific referrals. And there have been some recent changes that suggest that high-risk HPV testing is performed for two groups of patients, those being the low-grade screening cytology samples and the patients after treatment who have either a negative or a low-grade smear result. Now, for those patients which we call test of cure, if the HPV test is negative, then they get discharged to 3-yearly smears, which is the same as the general population. If the HPV test is positive, then they come to colposcopy, and from colposcopy we need to decide what the further management is going to be. So in Gateshead we have been using DySIS since February 2013, and up until now we have seen and examined more than 400 patients with DySIS, and we are auditing our results in specific patient groups, aiming to assess the accuracy of DySIS for those patient groups in particular and see if they can help us improve our management. The first group of patients I'm going to present as our results on is the test of cure patients. So like I said before, these patients come to colposcopy, and if colposcopy is considered to be negative, or if we perform biopsies for them and biopsies are negative, then we are supposed to discharge them to 3-yearly smears, which is the same as the general population. And we all know that this is a high-risk population, a high-risk group, and the risk for cancer for them is 5 times greater than the risk for the rest of the general population, and that is the case for at least 20 years after they have the treatment. And it's also a newly introduced group of patients, and there is no long-term data available on accuracy of colposcopy for these patients. But also there is no data so far on the performance of DySIS on the regenerated epithelium after treatment. So this is an observational study, and the population is the test of cure patients which are referred to our clinic. And the objectives of this study is to assess the accuracy of the DySIS map in detecting CIN2 class disease, and also, which is more important, to assess the combined performance of colposcopy and DySIS. And we're also hoping to assess a threshold in the DySIS mapping scale above which DySIS can guide us and suggest that that lesion might be a high-grade lesion. The endpoint we're using is histologically confirmed CIN2 class. So from the test of cure patients that are referred to our clinic, we have analyzed the results for those that had a normal cytology referral and were high-risk HPV positive, because we think that that subgroup in particular is the most challenging and the most interesting one. So far we had 91 patients in that group, and we have histology available for 68 of them, meaning that the rest of them were considered to have a normal colposcopy, so we haven't performed a biopsy. And you can see in the graph the histology outcomes for them, and you can see that the biopsies we performed were actually high grade for 8% of them. And here you can see that the colposcopic impression was high grade in 5% of these patients, but the DySIS map prediction was high grade for 57% of them, which is a much higher percentage, and it shows how much more sensitive it is, but again, it will result on having more false positive results. So in absolute numbers, we only had 5 patients so far that had a biopsy which was high grade, but if we try and calculate sensitivity, specificity, negative and positive predictive value for these patients, you can see that actually sensitivity is very low for colposcopy, but seems to really improve when we integrate the DySIS map prediction. The second group of patients I'm going to present here results for is the patients who were referred with a low-grade smear and were found to be high-risk HIV positive in the same sample. So this is a group of patients that represents different challenges. It's usually young patients. Colposcopy is quite likely to be negative for them. But then again, we know from the sentinel site study that there is an at least 16% high-grade disease hovering amongst those patients. And the DySIS was found to increase sensitivity for those groups of patients. Ms. Fisher also addressed that before. And it hasn't been published so far, but these are both studies that were presented in conferences. And the cohorts that we're referring to were cohorts of populations with either mixed or non-HPV status. We also know from the sentinel site study that patients who had a low-grade smear and were referred for that, if they have a negative colposcopy, then they have a risk of developing CIN2+ in the next 3 years, which is 4.4%, when the same risk for the normal screen population is 1.2%. Nevertheless, this triple risk, 3 times higher risk, was considered adequate, so that if you have a negative colposcopy, you would start this patient to 3 yearly smears. And from the ATLS study, what they tried to see was that if we can use colposcopy characteristics to actually decide which acetowhite lesions should be biopsied. And what they've concluded in this study is that if you use colposcopy characteristics to try and decide which acetowhite lesions should be biopsied, then you will miss high-grade disease for low-grade referrals. So again, this is an observational study, and we're including the low-grade, high-risk HPV positive referrals. And again, we're trying to assess the accuracy of the DySIS map in detecting high-grade CIN and the combined performance of the colposcopy and DySIS together. But also with this, we're hoping to be able to establish the negative predictive value of the DySIS map when colposcopy is negative, and see if when DySIS map is negative and colposcopy is negative predictive value high enough so that we can omit biopsies for these patients. And also we're hoping to find if DySIS can help us to decide which would be the best place to take a biopsy from. So again in the same time period, we have 99 patients which were low-grade referrals and were examined by DySIS, and we have histology for 76 of them. And you can see that amongst those with available histology, 21 of them had an actual histology result which was high grade, and you can see on the graph on the right what the results were in detail. In absolute numbers, we had in this cohort we had 16 high grade biopsy results, and 66 of them which were normal or low grade. And again here the colposcopic impression was 10%, for 10% of the population was high grade, and the DySIS map high grade prediction was much higher, 65%. If we divide, subcategorize to the borderline and the mild scoliosis referrals, you can see that there isn't a lot much of a difference between them. The results are similar for both subgroups. And again, if we calculate sensitivity, specificity, negative and positive predictive value for the detection of CIN2+ for patients referred with low-grade, high-risk HPV positive cytology, then we see that the colposcopic sensitivity is very low, and it it actually improves a lot when we integrate the DySIS map. And we accept that we cannot assess negative predictive value accurately by using the histology result, the biopsy result, but if we use that to try and assess negative predictive value for patients who have low-grade cytology and normal or low-grade colposcopy, we get a result of 88%. So to conclude, for the test of cure patients with normal smears and high-risk HPV positive, there is a trend that shows that there is a very low sensitivity for colposcopy, but it's improving a lot when DySIS is integrated. For the low-grade referrals, we are finding so far a similar sensitivity to previous studies, which were performed in cohorts of patients with either unknown or mixed HPV status, and the negative predictive value needs yet to be assessed, and we need larger numbers to assess it. As far as future targets are concerned, we want to establish if the colposcopist would biopsy and where from before the map, the DySIS map indication. And by that I mean that we believe that the true value of DySIS lies on if it adds in picking up high-grade disease. In other words, if you think the colposcopy is low-grade and you would biopsy it anywhere and then pick up high-grade disease, then you wouldn't miss the disease. But if we find out that you would biopsy from a different place and the DySIS map actually shows you where to biopsy and from, and you pick up high-grade disease that would otherwise be missed, then there is a true value. We definitely need larger numbers to allow set conclusions for patient groups of high clinical interest. We're aiming in using DySIS to standardize care between different centres in the UK. And as far as the high-grade referrals group is concerned, we are aiming to perform some research in order to assess if DySIS can assist in reducing over-treatment, as in choosing between see and treat and select and treat options. So these are our results, and I am now going to present to you some interesting case studies. So we have chosen representative studies from different groups to present to you. The first patient belongs to a low-grade dyskaryosis referral group. So she is a 37-year-old patient who is a para-5, and she's a smoker. She's not using any contraception, and she didn't have any symptoms or comorbidities when she attended. She did have a borderline cytology sample in 2010, and then 2 subsequent negative ones, 1 year apart, and then she was referred here in January 2013 with a borderline high-risk HPV positive smear. So this was the cervix before the application of acetic acid, and this was 2 to 3 minutes after the application of acetic acid. So this was considered as a low-grade colposcopy by the colposcopist who examined the patient, and this was the DySIS map. So I don't know how well you can see it. There is a little cross here. This is the area where we performed the biopsy from, as per indication from the DySIS map. So the result of this biopsy came back as CAN2, and the patient went on to have a loop biopsy of the cervix, which showed CAN2 completely excised, and subsequently received a test of cure cytology, which was negative, high-risk HPV negative. Therefore, she is now discharged to 3 yearly smears. The next case is from the high-grade dyskaryosis group. So this is a 25-year-old lady, para-1. She's not a smoker, and she's using the combined pill for contraception. She didn't have any symptoms or comorbidities when she was referred. And this was a cytology sample that she had in August 2013. It was her first smear, and it was a severe dyskaryosis one. So this was her cervix before the application of acetic acid, and this was after the application of acetic acid, and it was considered to be high-grade colposcopy. And you can see the map, which is definitely high grade as well. So she had a loop biopsy. She actually had CN treat on the same visit. She had her treatment, and it showed CIN3 involving the ectocervical and left lateral margin on the histology specimen. So she received follow-up cytology in May 2014, which was negative, high-risk HPV negative. She also had a colposcopy. She attended for a colposcopy when we performed her smear, which was also negative, and she's now discharged to 3 years smears. This patient is from the high-grade dyskaryosis referral group as well. She's a 31-year-old lady, para-2, non-smoker. She's using the Iplenon for contraception, no symptoms, no comorbidities. She had a smear in 2007, which was negative. Her next smear, 2009, negative again. And then she was referred to clinic in 2013 with a severe dyskaryosis smear. This was her cervix before the application of acetic acid. This is after the application of acetic acid, so this is her colposcopy. And this was considered to be high grade. And there you can see the endocervix a little bit better. And this was the DySIS map, which was high grade as well. So we did perform a CA-treat for this lady as well, and the histology specimen showed CIN3 completely excised. She has received her follow-up cytology, her test of cure smear in April 2014, which was negative, but HPV couldn't be performed in the same specimen, therefore she is to attend for repeat cytology. The next patient is from the test of cure group. So this is a 33-year-old lady, para-1. She was a smoker. She was also using Iplenon for contraception. She didn't have any symptoms, and she did suffer from IBS, depression, and headaches. She had her loop biopsy in 2008 for CIN2, and after that she had 3 negative smears, and then she was referred to clinic in June 2013 with a borderline high-risk HPV positive cytology sample. So this was her cervix before applying acetic acid, and this is her colposcopy, which was considered by the colposcopist as showing HPV infection only. This was the map, therefore we have performed biopsies from this area, and the biopsies came up as CIN3. We went ahead to perform a loop biopsy, which showed CIN2 completely excised, and she is awaited to have her test of cure cytology, which is not yet performed. And this is the last patient we are going to present to you. This is a patient who has been seen with DySIS twice. So the first time she attended with a high-grade dyskaryosis smear, a moderate dyskaryosis smear actually, which was performed in 2013. She was a 28-year-old lady, para-non, non-smoker, not using any contraception, without any symptoms of concern. She was due to commence IVF treatment because of male factor infertility, and during her counseling she was counseled about cervical stenosis and incompetence in case she would need treatment. This is the image of her cervix before applying acetic acid, and this is her colposcopy. And this was the map. Therefore, it was decided to do select and treat for this lady, and the colposcopist who examined her performed 3 different biopsies from the sites that you can see here. So this is site 1, site 2, and site 3. And you can see here the results of the biopsies. So site 1 was CIN1, and the other 2 areas showed CIN2 and high-grade CIN in thin epithelium. She was seen back in clinic, she was cancelled and discussed again the results, and she opted to have treatment. So when she attended back to have her treatment, this was the cervix, how the cervix looked like before the application of acetic acid, and this is the colposcopy after the application of acetic acid, and this is the DySIS map. So you can see that the DySIS map is not showing any particular high-grade areas anymore than it did before. And we went ahead to do the loop biopsy as the lady has opted, and the loop biopsy specimen showed CAN1 and HPV only, and she hasn't received her test of Q cytology yet. So we have sent a letter to fertility clinic to advise them to assess the cervical length during pregnancy. So at this point, I'm going to change back to Alistair, and we are happy to answer any questions you would have for us.
First of all, Raj and Christine, let me say thank you very much on behalf of all the participants. Really, really fascinating presentations. We have had a few questions submitted, so with your permission, I'll just read them out to you and let you address them as you see fit. The first question says, your first case was a case of a small CIN2 lesion. Couldn't you have used DySIS to establish that she did not have any other lesions and would therefore be eligible for conservative management?
Yes, yes, that's a very good question actually. We could do, yes. As you know, we always individualize treatment in cervical pathology, so it will depend on who is the patient you have, what the lesion looks like, if it's CIN2 or CIN3. So if it's CIN2, we always discuss conservative treatment, and if the patient is happy on attending 6 monthly repeatedly for at least 2 to 3 visits, and she understands the risks and the benefits of that, and she hasn't completed her family, it's a young patient, then we're more than happy to, we actually support conservative management for this patient. If the patient has already completed their family and they're very worried about, they're very anxious about the situation, then some of them would rather go ahead and have the treatment at the time. We're actually thinking of using DySIS for all the patients that we're going to, with CIN2 that we're going to manage conservatively from now on. And I think it would be a very interesting thing to see, but I totally agree with you, yes.
Would it be possible if I just interjected? Thank you very much for that, Christina. And I just want to say, within our regulatory framework, traditionally, BSCCB guidance has been that patients who have high-grade disease, and that would include CIN2, are offered the option of treatment. And there is a lot of debate at a higher level at the moment within guidance as to what the correct management is of CIN2 patients. We're working on guidance based in 2010, and it hasn't been updated yet. It's due for update this year. So patients are advised as to what standard practices and then how we think we can best individualize it. And in fact, DySIS is very helpful for us in helping to be specific in that guidance.
If I can just add as well that what DySIS has allowed us to do is be much more conservative with the high-grade smear referrals. So we are now, during the course of the last year, moving away from a see and treat policy, especially for younger women, and moving more towards a select and treat supported by the DySIS Colposcope. And that's on the background of the work that's been done, in particular regarding obstetric outcomes following treatment, but also in relation to some of the more reassuring information and evidence that we're now receiving regards conservative management of CIN2 lesions.
Thank you for all those answers. The next question is one, I think, straight from the heart. It says, have you honestly been surprised by the DySIS map results compared to your own professional assessment?
Christina, would you like to start again?
Yes. I have to say I have been, yes. And initially at the beginning, now the more I work with DySIS, the more I expect this to happen, so I'm not as surprised, but especially for test of Q patients, I have been. And I have to say, at the beginning, there were some patients that I wouldn't biopsy if I thought colposcopy was completely negative, but after I've seen a few that had a negative colposcopy, I thought, but they had something coming up on DySIS map, and I would biopsy it, and it came back as high grade. I had a couple at the beginning, and since then I biopsy everybody. I have been surprised in many cases. Not most of them, most of the times, you know, your colposcopic assessment is correct, but especially for specific groups, and I think test of cure is the most challenging group because of the scar tissue.
Would you like to add a few words?
No, I'll agree with Christina. I think colposcopists have a tendency to think that we're all quite fantastic at the job we do, but when we look at our audit and we look at the real numbers of what our sensitivities and specificities are, clearly the DySIS provides with that objectivity, definitely.
I mean, I'd just like to add a few words, and to be brutally honest, we first experienced the DySIS Colposcope, I think, close to 2 years ago, and the company offered us the machine for a short period to experience it. And our initial experience was that it was different to what we were used to. It seemed to take a bit longer. The ergonomics were a bit different. And through patients and working with DySIS Medical, there's been some modifications to the design of the instrument during the course of that time. There's also been changes to the software in terms of how the information is uploaded onto the system and how it can now link into the hospital intranet. That also improves time. And as with any new instrument or any new innovation, I think once you gain more and more experience with it, you then start noticing the benefits. And what we have noticed, accepting that it's different in some ways to what we're familiar with, is that it does improve sensitivity, it does improve objectivity, and it does provide some standardization, and improves also our documentation and recording of the actual examination itself. So I think for all those benefits, I think we've all had similar experiences during the course of our learning curve, but I think our collective opinion now is that we will, as we replace our remaining colposcopes, the intention will be to purchase and replace them with DySIS colposcopes.
Very good. Thanks, Raj, for that. Let me pick up on a couple of points you made there, which cover two other questions that have come in. First of all, how much longer does a DySIS colposcopy examination take than a conventional one, and what was your experience of the learning curve in terms of accommodating the different, slightly different procedure that DySIS follows?
Yeah, I think, if we each answer that question.
Yeah.
Christina, try to start.
Yeah, I think you're right. I would say it takes a couple of minutes more. It's always tempting to, because you have the image in front of you shown so nicely, so it's always tempting to explain to the patient longer. So I think that's the main reason why people have the impression that it takes much longer. And you talk to the patient more, but from technical point of view, I think the difference would be 2 minutes maximum. On the learning, as regarding the learning curve, I think if you use it for if you see something like 20 patients with it, that should be enough, 10 to 20 patients. Of course, you get better the longer time you use it, but after, and you need to use it quite often at the beginning so that you get the touch of it. But I would say around that amount of time. What do you think, Anne?
Yeah, I agree, Christina. The image takes about 185 seconds to acquire, and it's sometimes a little shorter time. If the image is acquired before, then the machine will let you know that. But that about 3-minute period can seem an awfully long time when you're sitting. It's not a problem for Christina because she talks a lot, so that's very easy for her to whittle the time away. But actually it does allow you to talk to patients. Most patients choose to have a look at their images on the high resolution screen you had. I did have someone who wanted to put her image on Facebook the other day, but that's another thing that we won't go on to. As far as the learning curve, for me, I found I needed a good 20 patients looking at low-grade cytology patients initially, just to get used to the diagnostics, because you don't have your the same binocular vision as you have looking down a lot of conventional colposcopes. And my greatest anxiety was the issue of actually connecting the DySIS colposcope to the speculum inserted in the patient. And for me, that felt like a big sticking point. I was really worried that would be uncomfortable. What if I jolted it when I introduced that? And actually, that is just the least concerning aspect for me now. You need to just get a little bit slick at how to centralize the cervix, because you don't have the opportunity to maneuver the colposcope around once it's attached. But actually, that takes, I would think, about 20 cases to become confident with that. So there's the issue of confidence for diagnostics, and then there's the issue of confidence for treatments. And your ergonomics are slightly different for doing treatments using a LETS or a loop biopsy, and to aid in the performance of this, because clearly we were very certain that we in no way would want our patients to receive an inferior loop biopsy or an inferior treatment. So to aid in this, the company has done a lot of development of the actual equipment. So we now have loop biopsies in balls with a longer shaft and with an angle and with slightly different ergonomics. Again, I had a learning curve, I would guess, of about 10 loop patients to be a lot more confident in doing those. So it's a little bit extra time and just some change in ergonomics. But I feel, again, I was skeptical in the beginning, but I feel from using it, and I now try to exclusively use a DySIS Colposcope if I can get Christina off it in the clinic, then I definitely feel that it adds value for the colposcopy that I was performing. Yeah.
Thanks, Anne. I mean,
Thank you very much.
If I can just add to that, Alistair, I think you know, our experience initially, which was that you'd left the colposcope with us and we were experiencing it on our own. I think our initial experience was that things were taking longer in terms of connecting to the speculum, spraying the acetic acid on, getting familiar with the software. And having then fed that back to you, what you then provided was proper official intensive training with the use of a DySIS trainer. And we then allocated training times for each of the colposcopists within the department with the trainer. And what we found was a huge difference in how we were then able to familiarize ourselves with the new instrument. And I think it was on the background of that official training that I think we then experienced the real benefits very, very quickly. And I think on the back of, in fact, for my training, I think the trainer was not present, and Christina actually trained me. Christina, was it 5 days, I think, to get me up to a reasonable standard?
Yeah, to get me over there.
So I think I just wanted to support what Christina and Anne have said, but also to stress the point that I think there is value in having an official trainer involved once you do purchase the DySIS Colposcope.
Perfect, thank Raj. I think from the company point of view, we'd absolutely reinforce that, and we do offer, you know, very, very focused, intensive clinical training for as long as it takes for a clinician to get used to DySIS. I do have a question on that line that's come in from the US that reads, I have used DySIS in the US approximately 5 times, and I'm wondering if you have any tips or tricks on getting a complete view of the cervix once the speculum is attached to the optical head.
Christina.
We have actually. So what you can do is you can do 2 things. One thing is you can not attach it completely to the speculum. So by not attaching it completely, you can give an angle to the optical head, and that way you can see the cervix better, because we all know sometimes the cervix is misplaced and or it has a different angle. So you can't, it's very difficult to centralize it, whatever you do, if you attach the speculum completely. The other thing you can do is you can use a cotton ball and press on the cervix, on the posterior fornix usually. What you need to do is you need to have one of your hands pressing, usually the left one, pressing on the posterior fornix with a cotton ball, so that you centralize the cervix, and then you do the colposcopy like that. If you do that, it's usually better to have the speculum completely attached because it reduces the artifact from the movement. So you can usually, if you end up using the cotton ball, you can usually centralize the cervix quite nicely, even if you have the speculum attached. So what I mean is, if you have both the cotton ball and you don't attach the speculum completely, then you have a higher chance of having moving artifacts during the colposcopy.
And can I just say one more thing, is that you don't actually have to use the DySIS speculum. You need to make sure your focal length is correct, so you need to bring the optical head in quite close, the equivalent to what you do. But if you feel for that particular patient the speculums available to you are not allowing you to get a centralized vision, by all means put in a normal, whatever appropriate speculum is for you. That might be something to hold the side walls in place, or to give you a slightly adjusted view, and just use that. That's okay as well.
Good.
Again, just to add, I think during the course of the last year there have been some design improvements in the specula, especially the treatment specula, and I think we have to accept that the DySIS Colposcope is fairly new as an adjunct and as a technology, so I think we can expect further improvements with that.
I'm sorry, can I add one more thing, Alistair? Even if I understand that sometimes it's very difficult technically, and some ladies have very large cervixes and you can't visualize the whole cervix. Even if that is the case, you're only going to have a DySIS map for as much as you can see, but it doesn't mean that you cannot perform a colposcopy for the rest of the cervix. So you can still have your conventional colposcopy for the rest of the cervix. So what you can do is you centralize as well as you can. You do your DySIS, you have your map, and then you can just visualize the rest of the cervix, move the speculum around, move your cotton ball around, spray again, and visualize the rest of the cervix. So you can still do conventional colposcopy, so you're not missing anything to a conventional colposcope. If you don't centralize properly, or it's not feasible to centralize as well as you would like, then you're not going to have the map for the whole of the cervix.
Very good. Thank you all for that. There's a very brief question which I will answer on behalf of the company. It simply says, are there any consumables with the product? And the answer is that we have a range of specula that are reusable, the conventional metal reusable ones, but we also have disposable specula that we're in the process of introducing. They're not available in the US yet because we'll still have to go through FDA approval for those, but as soon as that's done, we'll be introducing those. Beyond that, the only other consumable is the acetic acid kit that is used to apply the acetic acid by the clinician. And we do recommend that that is changed periodically just to maintain the equipment in a high-performing nature. And finally, the only other consumables that's worth mentioning is we have our own range of loops and balls that are used for treatment. As I think it was Anne described earlier on, they are of a slightly different design, which really facilitate the ergonomics of performing treatment whilst using DySIS, and they're available from us as well. I'm very conscious of time pushing on here, so I've got one last question for you, the NGOC team, that says, is there any difference in endocervical assessment with DySIS with often restricted access with Kogan speculum?
Okay, do you want to start again, Christina?
I will. Thank you. Thank you, Raj. You only have a map for what you can see when you spray the acetic acid. In the process of the DySIS Colposcope measuring the acetowhitening effects and producing the map, you cannot intervene. So you cannot use the Kogans and open and visualize the endocervix. So what you can, the way you visualize the endocervix and assess the endocervix is the same as you would do with a conventional colposcopy. So you only have the map to whatever you can see when you place your speculum and visualize the cervix. And then, like I said before, you can just do the rest of the assessment you need to do as you would do normally, as in use your Kogans, spray again, and visualize the endocervix better.
That's right.
Excellent, thank you. Well, with that, let me conclude this webinar by saying a terrific vote of thank yous from all of the attendees online. As I said, we've got a huge number of people listening into this from a vast array of countries, extending from Japan right across to the US. So Raj, Christina and Anne, thank you very much indeed for your precious time, giving your precious time up to this webinar. We really appreciate your in-depth view, the case studies, and answering questions for us. And for any of the attendees who are listening and watching, that beautiful picture that you can see on your screen at the moment is the Millennium Bridge in Gateshead in the UK, and it is the most phenomenal tourist attraction. So if you're ever in the UK, I would really encourage you to go to Gateshead and take a closer look. Thank you all very much indeed.
Thank you, Alistair.
Thank you very much. Thank you.